Rhabdomyolysis is caused by the breakdown of the skeletal muscle and dispersing intracellular components like electrolytes into the circulation. It often occurs after the pressure is relieved from the damaged tissue and the necrotic tissue releases its components. The primary role for therapists is knowing the symptoms and being able to notice them in order to go to the respectable person so the patient can receive testing and treatment before an acute kidney injury occurs. Causes of rhabdomyolysis could be congenital or acquired. Acquired causes are overexertion, trauma, drugs, infections, toxins, muscle ischemia, or increased temperature. Overexertion rhabdomyolysis normally occurs in strenuous exercisers like marathon runners, military recruits, and people who participate in CrossFit. People who have seizures may result in acute severe rhabdomyolysis because of ATP being on high demand, which leads to membrane homeostasis unable to be maintained. Risk factors for exertional rhabdomyolysis are hypokalemia, the sickle cell trait, extreme humidity, or exercise-induced asthma because these abnormalities disrupt the cell membrane homeostasis. Trauma that can cause rhabdomyolysis are terror attacks, bombings, earthquakes, electrical injuries, or third-degree burns. In burns, the late onset of rhabdomyolysis is possible and could be caused because of immobilization or burn contractures. Drugs that can cause rhabdomyolysis are ethanol, heroin, tobacco, cocaine, or alcohol. Substance abusers are often malnourished, which results in a lack of glycogen storage and ATP reserve. Long-term over-the-counter drugs may lead to rhabdomyolysis because cholesterol is an important part of the cell's membrane and the synthesis is blocked the result is unstable skeletal muscle membrane. Toxins that cause rhabdomyolysis are carbon monoxide, snake or spider venom, or quail eating. Muscle ischemia that can cause rhabdomyolysis could happen from shock, hypotension, or the sickle cell trait. It could be localized like blood vessel thrombosis, embolism, compartment syndrome, or tight dressings like cast or surgical tourniquets. Muscle ischemia is when the muscle tissues are deprived of oxygen, which decreases the levels of ATP production that leads to necrosis of the muscle cells. Risk factors for this type of rhabdomyolysis are being overweight, undergoing surgery for more than 5 to 6 hours at a time, circulatory volume depletion, or pre-existing diabetes. Increased temperature like a heat stroke, malignant hyperthermia, or cold could also cause rhabdomyolysis. Extreme cold is extremely rare. Congenital causes of rhabdomyolysis are connective tissue disorders, muscular dystrophy, Becker's dystrophy, or endocrine abnormalities like Addison's disease, hyperthyroidism, or hypothyroidism. Diagnosing rhabdomyolysis is primarily based on suspicion of the possibility and a thorough history because clinical presentation may be minimal or absent. Muscle weakness, aches, tea-colored urine, muscle tenderness, swelling, cramping, and stiffness in the lower back, thighs, or calves, blisters, or discoloration to the limb indentation may be present. Confirmation of rhabdomyolysis is made by laboratory tests, specifically for urine myoglobin. Skeletal muscle biopsy is available but not necessary and normally only used in pediatrics due to the possibility of genetic disorder being present. CT and MRI can also be used to confirm the diagnosis. A CT detects muscular swelling and edema, which suggests muscle necrosis. An MRI, which is the most effective and may serve as a decision-making tool, places a contrast between healthy and damaged muscle. The prognosis of rhabdomyolysis is dependent upon the underlying cause. If the underlying cause is not genetic and is diagnosed early and treated aggressively, the prognosis and renal function recovery is excellent. For the treatment, there is no sufficient evidence studies on the management of rhabdomyolysis, but the treatment used for rhabdomyolysis is vigorous rehydration, elimination of the underlying cause, and prevention of complications. Complications that may arise from rhabdomyolysis are volume depletion, compartment syndrome, acute kidney injury, or acidosis. Impairments that these patients may present are pain, range of motion, strength, and balance deficits. Interventions for these patients are light exercise, balance activities, active range of motion, passive range of motion, and modalities. Neuromuscular electrical stimulation and heavy exercise is contraindicated due to the possibility of overexerting the muscle and causing more breakdown. Patient education for these patients consists of to inform them to avoid overexertion, they need to stay hydrated, and they need. Next is an example of why we must stay suspicious of patients presenting with rhabdomyolysis. This patient in this case had had a shoulder surgery, and he came in with all of the symptoms of rhabdomyolysis. To keep an eye on their urine color.
Today I was just going to work with your shoulder. How is it feeling today?
Oh, my shoulder feels fine.
Are you having any other complaints? Is anything bothering you?
Well, as a matter of fact, my lower back has been aching, and it's like twitching, like spasming, and it's real tender to the touch.
Okay. Can you think of anything that you've done? Have you picked up anything heavy or done anything like that?
Not that I can remember.
Okay. Now your urine, has it been a different color than it normally is?
Well, now that you bring it up, it is kind of like a dark tea color.
Okay. Give me just a second and I'll be right back, okay?
All right, yes, ma'am.